Αγαπητοί συνάδελφοι, καλημέρα. Καλημερίζω όλους τους παρόντες και αυτούς οι οποίοι ξυπνήσανε πρωί-πρωί για να μας δουν διαδικτυακά και τους ευχαριστώ πολύ γι' αυτό. Το πρωινό τραπέζι είναι πολύ ενδιαφέρον, ακόμη και είναι πρωινό, και αφορά το πρόβλημα το οποίο μαστίζει τα ελληνικά νοσοκομεία και αφορά την ορθολογική χρήση των αντιμικροβιακών φαρμάκων. Γνωρίζουμε όλοι ότι τα ελληνικά νοσοκομεία είναι πρωταθλητές στην κατανάλωση αντιβιωτικών και αυτό βέβαια έχει τις συνέπειες του, οι οποίες είμαστε και πρωταθλητές στον υπολασμό των πολυανθρητικών μικροβίων. Επομένως, για να μην καθυστερούμε άλλο, προχωρώ αμέσως. Καταρχάς, καλημερίζω τον συμπρόεδρό μας, τον κύριο Θ.Ζαούτη. Καλημέρα, Θεοκλή.
Καλημέρα σας, καλημέρα σας.
Εισάγω λοιπόν τον πρώτο μας ομιλητή, ο οποίος είναι ο κύριος Ζαούτης. Γνωρίζουμε ότι είναι ο πρόεδρος του ΙΟΔΗ, είναι επίσης καθηγητής του ΕΚΠΑ, αλλά και σε πανεπιστήμιο στην Πενσιλβάνια των ΗΠΑ. Είναι παιδίατρος λοιμοξιολόγος κατ' εκπαίδευση και φυσικά έχει μεγάλο επιδημιολογικό background ως πρόεδρος του ΙΟΔΗ. Η εισήγηση την οποία θα μας κάνει ο κύριος Ζαούτης είναι ορθολογική χρήση αντιμικροβιακών στην αιματολογική κλινική. Κύριε Ζαούτη, έχετε το λόγο.
Καλημέρα και από μένα. Δυστυχώς δεν μπορούσα να βρεθώ μαζί σας, αν και ήταν προγραμματισμένο. Όπου ένα λεπτάκι να ανεβάσω τις διαφάνειες. Ως συνήθως, για τους περισσότερους που με γνωρίζετε, τις ομιλίες μου τις δίνω στα αγγλικά, γιατί είναι η γλώσσα του επαγγέλματος και η γλώσσα στην οποία έχω δουλέψει και έχω ερευνήσει, και τη συζήτηση θα μπορούμε να την κάνουμε στα ελληνικά. What are we going to talk about today? We're going to talk about antimicrobial resistance, the problem of resistance, as Professor Sipsas mentioned in Greece. Then we're going to talk specifically about the topic today, which is antimicrobial stewardship, how we can use antibiotics in a more judicious manner in hematology oncology patients. And then briefly at the end, talk about where we are with healthcare acquired or nosocomial infections in Greece. So antimicrobial resistance during the COVID-19 pandemic has been titled the silent pandemic. The pandemic under the pandemic we don't talk about. Although antibiotic resistance isn't as striking as the COVID-19 pandemic, it has a very significant impact on health, including lives lost and costs. This was a study that many of you recognize. This was looking at attributable deaths and disability-adjusted life years. How many life years of effective quality life we lose and death caused by antibiotic-resistant bacteria in the European Union. This was a 2015 paper published in Lancet. And here's the DALYs, they're called, the disability-adjusted life years. The country with the highest lost life years was Italy, and Greece was second, followed by Romania, Portugal, and Cyprus. The different colors represent different organs. Now, in 2020, Greece leads the European Union in the estimates of the burden of infections and the disability-adjusted life years due to antibiotic-resistant organisms per 100,000 population. So we were second in 2015, we are first in 2020. This is the most recent data on antibiotic resistance in Europe. Specifically, I think we've seen these maps before. This is the most recent data. They look like the older data. This is Klebsiella pneumoniae resistant to carbapenems by country. The dark red countries have greater than 50% of their Klebsiella isolates resistant to carbapenems. And within the European Union, we are the country with the dark red. And then the rest is Eastern Europe and Asia. If we look at Acinetobacter species, Acinetobacter species resistant to carbapenems is more widespread in Southern Europe, as well as here, the Balkans and Asia. Professor Sipsas mentioned antibiotic consumption. This is the most recent data from 2021 from the ECDC. And here's the total consumption of antibacterials in the EU expressed as DDDs, defined daily doses per 1,000 inhabitants. Romania is at, in 2021, is at 25.7. Cyprus is at 25 and Greece is at 23.5. So we rank third in the European Union in total antibiotic consumption. The average, which you see down at the bottom of the screen, is for the EU is 16.4 DDDs per 1,000 inhabitants. Let's take a look at the deaths attributable and associated with resistance by pathogen. And this is, I want to marry this data here with the data that I just showed you on Acinetobacter and Klebsiella. If we look at attributable death due to antibiotic resistance, Klebsiella and Acinetobacter are third and fifth. So two of the organisms that rank in the top 5 for attributable deaths are the ones that we struggle the most in Greece, as you saw earlier in terms of carbapenem-resistant infections. What happened during COVID-19 globally is that we saw an increase in resistant hospital onset infections and deaths. This is CDC data in the United States. Resistant infections increased by 15%. Significant increases in hospital-acquired infections. And many of these hospital-acquired infections are resistant to antibiotics or antifungals. And acute care hospitals saw more Candida auris infections, including in COVID-19 units. Here's the increases described by the CDC. As you see, everything is in the upwards direction. Increases in carbapenem-resistant Acinetobacter, Candida auris, carbapenem-resistant Enterobacteriaceae, Candida, ESBLs, VRE, multi-drug-resistant Pseudomonas, and MRSA, all the organisms that we worry about in high-risk and immunocompromised patients. This is Greek data from HUNET during COVID-19, and we see that if you look at the different, the directions of the curves, Acinetobacter is the blue. We see increases in ICU Acinetobacter. We see increases in a number of different organisms. More specifically, Acinetobacter and Klebsiella increase steadily, carbapenem-resistant organisms. Klebsiella pneumonia, the same thing. Enterococcus faecium and Staph aureus. The only organisms that we saw decrease in was Pseudomonas aeruginosa in the Greek data. So let's move from antibiotic resistance to antimicrobial stewardship. What is antimicrobial stewardship? It's the coordinated program that promotes the appropriate use of antimicrobials, improves our patients' outcomes, reduces resistance, and decreases the spread of infections caused by multi-drug resistant organisms. The question I think today that needs to be asked in this specific 20 minutes is, can we do this in hematology patients? And this is a paper, it's not a number of years, came out of SMID and a joint group, the role of antimicrobial stewardship in limiting antibacterial resistance among hematology patients. And this was on behalf of the ESIL-4 group, the European Council on Leukemia, and was jointly published by a number of major organizations, the Immunocompromised Host Society, I mentioned SMID, and the European Organization for Research and Treatment of Cancer. And what did they tell us? The principles of antimicrobial stewardship for hematology patients. We should start antibiotics if the patient has fever or is sick, not based on biomarkers such as C-reactive protein. Starting antibiotics in patients like that have shown inconsistent results, and antibiotics should not be initiated on the basis of colonization. Antibiotic treatment should be started after taking at least 2 blood cultures in the suspected site of infection. We should use the MASC score to guide our decisions on low risk and high risk patients. Initial empirical therapy should cover virulent gram-negative, Pseudomonas, Staph aureus, including MRSA, depending on the local epidemiology. We should develop management algorithms. I think many of us know what we need to do and what the guidelines are. It's a matter of implementing these algorithms in our institutions. Strategies exist to reassess empiric antibiotic therapy after 2 to 3 days. We should also let these algorithms guide our treatment duration, and we should individualize our risk assessments. So this is from the EASL 4 group. Our hematology units should have epidemiological data on blood isolates. We should know the epidemiology of the organisms in our units. We should follow the outcomes. We should have a multidisciplinary group, hematologists, microbiologists, pharmacists, who participate in antibiotic stewardship decisions. We should again develop these protocols on diagnosis, treatment, and prophylaxis of fever during neutropenia, and provide infectious disease education for hematology and hematology training for ID physicians. Sometimes we talk about, the hematologist should learn infectious diseases. The ID physician should also know something about hematology and oncology in order to work together. These are the European guidelines for empiric antimicrobial therapy for febrile neutropenic patients. This is EASL. The EASL guidelines, again, multiple groups participated in this. And they discuss 2 different approaches, the escalation approach and the de-escalation approach. The escalation approach is probably not appropriate for most of our units in Greece, because the approach represents an approach to patients who don't have colonization with resistant infections, resistant bacteria, and no previous infection with resistant bacteria, and centers where resistant pathogens is rarely seen. I don't think we are epidemiologically in a situation where we could follow the escalation approach. What are the definitions of these 2 approaches in febrile neutropenia? The escalation approach is starting with something narrow spectrum, ceftazidime, cefepime, or piperacillin tazobactam. And if the patient deteriorates or a resistant pathogen is isolated, therapy is escalated, hence escalation approach. The de-escalation strategy is defined as giving a broad initial empiric therapy covering ESBLs, including the early use of carbapenems or colistin in combination with other agents. Therapy is then de-escalated to a narrow spectrum antibiotic once our laboratory does not report that we have a resistant pathogen. Here are the guidelines for de-escalation. Like I said, de-escalation is what we can probably apply in Greece. Carbapenems are indicated as first-line therapy in seriously ill patients, those who have known colonization or previous infection with ESBL or resistant gram-negatives, or centers with high prevalence of infections due to ESBLs at the onset of febrile neutropenia. We should add a gram-negative, an aminoglycoside, in seriously ill patients, or if Pseudomonas or Acinetobacter are likely based on our local epidemiology. And in terms of gram-positives, we should add an antibiotic with broader gram-positive, vancomycin, teicoplanin, linezolid. If patient is very sick and septic, if colonization with MRSA or VRE, if we think it's a catheter-related infection, or there's a skin and soft tissue infection, which is likely caused by a gram-negative. In the de-escalation approach, if no bacteria are documented and the patient is deteriorating, consider the addition of antibiotics, including colistin, depending on the history. In an afebrile patient, if there's a documented infection, consider stopping the aminoglycoside, the quinolone or colistin, or the anti-gram-positive agent, depending on the organism. Consider stopping antibacterial therapy at greater than 72 hours if patient has been afebrile for 48 hours. Of course, if the patient is seriously ill, keep on the initial regimen. So those are the guidelines, the guidance for antibiotic use. What are the practices in febrile neutropenia across Europe and Asia? This was the EBMT, the Bone Marrow Transplant Consortium survey in Europe. They sent questionnaires to 567 centers, 194 responded. Empirical combination therapy is used in stable patients without a history of resistant organisms in 37%. Glycopeptides, vancomycin, are added empirically when fever persists, regardless of whether the patient is unstable, in 60%. 71% escalate if fever persists for 3 to 5 days. In stable patients with a known pathogen, 30% do not de-escalate. In FUO, fever of unknown origin with uncomplicated presentation, 54% de-escalate, half do not. Is it safe to de-escalate and discontinue therapy? This is a study, again, by an EASL group published this year in JAC, Journal of Antimicrobial Chemotherapy. The premise of the study is that early antibiotic discontinuation, according to the EASL guidelines we saw, are not systematically applied. The study was conducted using an EASL-4 cohort of patients, and they looked at early discontinuation of antibiotic therapy during fever of unknown origin in induction therapy, so relatively high-risk patients for leukemia or bone marrow transplantation. And early discontinuation was after at least 72 hours of IV if a patient had been afebrile for 48 hours and stable, irrespective of the ANC. Here's what the two groups look like, the early discontinuation group and the no discontinuation group in terms of outcomes. No difference in febrile recurrences, no difference in ICU admission, no difference in septic shock, and no difference in 30-day mortality. Statistically significant differences. Besides the European guidelines, I think everybody here is aware of the fever neutropenia guidelines from the IDSA. Essentially very similar guidelines. They talk about using monotherapy unless the patient's really sick, so carbapenem or cefepime or piptazode. Vancomycin is not recommended as standard part of initial antibiotic regimen, and we should modify therapy if patients are at risk for resistant infections. Indications for adding a gram-positive agent: if the patient is sick, if there's pneumonia, if there's a positive blood culture for gram-positive, a catheter-related infection, skin or soft tissue infection, colonization with a resistant gram-positive, or severe mucositis if fluoroquinolone prophylaxis has been given and ceftazidime has been used. Very similar, if we look at the EASL-4 guidelines and the IDSA guidelines, very similar in terms of how we should guide antibacterial therapy in fever neutropenia and hematology patients. Very similar as well in de-escalation. If the patient is stable, we should not be making an empiric change, even if they continue to be febrile. Documented clinical and microbiological infections should be treated with antibiotics appropriate for the site and susceptibilities. We should tailor our therapy for susceptibilities. As the last part of the talk today, I want to talk about healthcare-acquired infections, because we do have a situation here of the perfect storm. We saw antibiotic consumption, we saw high rates of resistance that we struggle with in our challenge in our hospitals in Greece. Preventing infections is one of the greatest tools for combating resistance. If you don't have an infection, you are unlikely to use antibiotics, and therefore the cycle of infection, antibiotics, and resistance can be broken. As many of you know, we have started, LV is coordinating a number of different efforts around collecting hospital infection data in Greece. And I'm going to show you some of the most recent data from that effort, which is a combination of ODP, LV, the ministry, and a number of other stakeholders, and the Infection Prevention Society of Greece. These are the CLABSI rates, the catheter-related bloodstream infection rates from 10 hospitals in Greece, 10 very large hospitals in Greece, during a period of 9 months between December 2021 and September 2022. And this is active surveillance. This is not point prevalence survey. This is actively counting CLABSIs for those 9 months in those 10 hospitals using CDC definitions. These are all the big hospitals. The median CLABSI rate was 7.75 per 1,000 catheter days, which is the metric that we should be using for CLABSIs. I chose to show CLABSI data here specifically to you because CLABSIs are the most common infections, central line associated infections, also in hematology patients. Here's the CLABSI rates of the two hospitals over time. We do see a slight decrease the last 3 months. Likely, my hypothesis is representing decreases in ICU pressure because of decreases in COVID-19 severity in hospitals. But the rate remains high at about the last few months between 5 and 6 per 1,000 catheter days. The next question is, how does that stock up? How is that benchmark against data from other places? I want to show you CLABSI rates from pre-COVID and during COVID. 2013 to 2018, 45 country survey of CLABSI rates done by a very strong consortium, infection control consortium, was 4.45. Between the years 2012 to 2017 in the United States, CDC data, CLABSI rates were 0.8. CDC during COVID-19 pandemic saw an increase to 1.16. There was a study from 7 low middle income countries, including India, Turkey, etc. During COVID, the CLABSI rate was 4.73, and data from our hospitals is 7.25. We have significant amount of work to do around CLABSI prevention and nosocomial infection prevention rate as part of our national strategy to reduce resistance. I'm going to become a little bit of a caricature in this data. We need to wash our hands. This is hand hygiene compliance data from the 10 hospitals I mentioned. We wash our hands about half the time. And this is active surveillance, over 10,000 hand hygiene observations, not a small sample. If we look at the pathogens that I showed you the CLABSI rates. If you look at the pathogens causing CLABSI in the 10 Greek hospitals, Klebsiella and Acinetobacter lead the list, account for about 40%. That is a very big problem because those are the two organisms that have the highest rates of resistance in our country. Candida auris, I know this has been a topic, and Professor Sipsas has talked a lot about it, accounted for about 4% of CLABSIs during that surveillance period. Fungemia in total was about 11%. 4.9 for parapsilosis, 3.9 for auris, and 2.8 for albicans. Here's our hand hygiene compliance data, looking at a closer look. I mentioned there were a total of 19,000 observations. Overall compliance was 47.2. The use of gloves occurred in 70%. Alcohol was used in half of the opportunities for hand hygiene, half. Doctors, slightly lower than nurses in terms of hand hygiene compliance. And what really interesting data, if we look at the different WHO moments of hand hygiene, the lowest compliance was with moment 1 and moment 5. If you look at those moments, those are the moments that are actually related more with protecting the patient than protecting ourselves. There's now some literature that suggests how the COVID-19 pandemic decreased our infection control efforts, and the effort was, of course, on reducing the spread of COVID to healthcare workers. In summary, antimicrobial resistance continues to be a major challenge globally, but in Greece as well. Antimicrobial stewardship is possible in hematology patients because the guidelines we have a high level of evidence. They are not weak guidelines for antibiotic therapy, but we need to be better at implementing them. There's data that stewardship in this hematology setting can be accomplished safely, and we need to take the opportunity to address resistance through preventing healthcare-acquired infections, and I think you'll hear more about infection control later in this roundtable. Thank you very much.
Ευχαριστούμε πολύ, κύριε Ζαούτη, για την παρουσίαση. Πιστεύω ότι οι αιματολόγοι κάνουν 2 μεγάλα λάθη. Το πρώτο είναι ότι ξεκινάνε στην επίρρητη ουτεροπενία απευθείας με μεροπενέμι, το οποίο είναι λάθος αν δεν έχει μικροβιολογικά δεδομένα. Και το δεύτερο είναι, ακόμη και αν ξεκινήσουν σωστά, εάν ο ασθενής παραμένει εμπειρητός μετά από 3 μέρες, χωρίς να υπάρχει κανένα μικροβιολογικό δεδομένο και ο ασθενής παραμένοντας σταθερός, κάνουν αναβάθμιση με μεροπενέμι. Δεν υπάρχει κανένας λόγος γι' αυτό. Απλώς καταστρέφει τη χλωρίδα του ασθενού σου, χωρίς να τον βοηθάς σε τίποτα. Τα data είναι πολύ πιστικά ότι δεν μπορεί να κάνεις αναβάθμιση εμπειρική σε πενέμες. Δεν προσφέρεις τίποτα στον ουδετεροπενικό ασθενή. Εάν αυτά τα 2 λάθη διορθωθούν, που στο δικό μας νοσοκομείο ευτυχώς διορθώθηκαν, η επίδραση στη χλωρίδα της κλινικής είναι άμεση και γρήγορη και εντυπωσιακή. Εντάξει, και νομίζω ότι το έχει κάνει σαφές και ο κύριος Ζαούτης στην ομιλία του, από τα στοιχεία τα οποία μας δίνουν οι Ευρωπαίοι και οι Αμερικάνοι, ότι δεν χρειάζεται αυτή η εμπειρική χορήγηση μεροπενέμης ή η εμπειρική αναβάθμιση μεροπενέμη στο ουδετεροπενικό ασθενή, αν δεν έχεις μικροβιολογικά δεδομένα.
Και να κάνουμε και το de-escalation όταν έχουμε δεδομένα με τα οποία μπορούμε να κάνουμε de-escalation. Και θα πρότεινα, είναι πάρα πολλά που μπορούμε να κάνουμε, να διαλέξουμε στις κλινικές μου κάτι. Ένα πραγματάκι, δηλαδή αυτά που είπες, κύριε Σίψα, δηλαδή να μην κάνουμε escalation ή να προσπαθήσουμε να κάνουμε de-escalation. Να ξεκινήσουμε αυτή την πορεία του stewardship με κάτι μικρό και θα κάνει μεγάλη διαφορά.